Pulsus paradoxus is a characteristic feature of cardiac tamponade. 30-year-old male comes with history of acute breathlessness, JVP, increased inspiratory fall of BP by 14 mm of mercury. True about this condition, low electric ECG, inspiratory fall of systemic fall of more than 10 mm mercury. All of the following may be seen in a patient of cardiac tamponade except Kussmaul sign. So what can be seen in cardiac tamponade? Pulsus paradoxus, electric alternance and right ventricular diastolic collapse on echocardiogram. All of the following are seen in cardiac tamponade except Kussmaul sign. What can be seen? Pulsus paradoxus, diastolic collapse of right ventricle on echocardiogram and electrical alternance. All are features seen in cardiac tamponade except rapid Y descent. So what can be seen in cardiac tamponade? Raised JVP, Kussmaul sign and pulsus paradoxus. During ventricular pressure, pulses square root wave is seen in constrictive pericarditis. Kussmaul sign is not seen in cardiac tamponade. It is seen in restrictive cardiomyopathy, constrictive pericarditis and right ventricular infarct. Not seen in constrictive pericarditis is acute pulmonary edema. What is seen in constrictive pericarditis? Ascites, tapping apex and pericardial knock. All are true in chronic constrictive pericarditis except commonest causes idiopathic. So what is true about chronic constrictive pericarditis? Kussmaul sign is present, ascites is not in proportion to edema, right ventricular and diastolic pressure is raised. Electrical alternance is seen in cardiac tamponade. A patient presents with engorged neck veins, BP 80/50 and pulse rate of 100 following blunt trauma to the chest. Diagnosis is cardiac tamponade. A young motorist suffered injuries in a major road traffic accident. He was diagnosed to have fracture of left femur and left humerus. He was also having fractures of multiple ribs anteriorly on both the sides. On examination, the blood pressure was 80/60 mm of mercury and heart rate was 140 per minute. The patient was agitated, restless and tachypnea. Jugular veins were distended. Air entry was adequate in both the lung fields. Heart sounds were barely audible. Femoral pulses were weakly palpable, but distally no pulsation could be felt. On priority basis, the immediate intervention would be urgent pericardial tap. A postoperative cardiac surgical patient developed sudden hypotension, raised central venous pressure, pulsus paradoxus at the fourth postoperative hour. The most probable diagnosis is cardiac tamponade. A patient presents with respiratory distress, hypotension and dilated bulging neck veins after chest trauma. Most likely cause is tension pneumothorax. Which of the following is least likely to cause constrictive pericarditis? Acute rheumatic fever. So which is more likely to cause constrictive pericarditis? Tuberculous pericardial effusion, staphylococcal effusion and post-cardiac surgery. A 30-year-old man presents with the fever and progressively increasing breathlessness since last 2 weeks. His clinical examination reveals pulse 120 per minute, regular, blood pressure 100/60 mm of mercury and muffled S1 and S2 heart sound. The distended jugular vein has a rapid X descent with an absent Y descent. What is the probable diagnosis? Cardiac tamponade. Other cardiomyopathy and pericarditis. Which one of the following is a cause for restrictive cardiomyopathy? Amyloidosis. False regarding restrictive cardiomyopathy is left ventricular hypertrophy and heart failure is not predominantly right sided. So what is true about restrictive cardiomyopathy? That filling pressure is increased. In early phase, systolic function is not impaired. To differentiate restrictive cardiomyopathy and constrictive pericarditis, features favoring constrictive pericarditis are diastolic pressure are equalized and thick pericardium is present. True statement regarding cardiac tamponade: enlargement of the cardiac cell house, electrical alternance and muffled heart sounds. Rapid X descent is unlikely in RVM. Hemorrhagic pericarditis occurs in all of the following conditions except constrictive pericarditis. So, hemorrhagic pericarditis occurs in transmural myocardial infarction, dissecting aneurysm of aorta, and metastatic disease of pericardium. Cardiomyopathy may be seen in all of the following except alkaptonuria. So, cardiomyopathy can be seen in Duchenne muscular dystrophy, Friedreich ataxia, and type IUI glycogen storage disease. All of the following conditions produce restrictive cardiomyopathy except hypothyroidism. So, amyloidosis, hypereosinophilic syndrome, and tropical endomyocardial fibrosis produce restrictive cardiomyopathy. True about pain of pericarditis is pain increases during inspiration and pain increasing on eating. What is the cause for hemorrhagic pericardial effusion except constrictive pericarditis? So, causes of hemorrhagic pericardial effusion is transmural myocardial infarction, aortic aneurysm dissection, and metastasis to pericardium. Kussmaul sign is seen in all except cardiac tamponade. It is seen in constrictive pericarditis, right ventricular infarct, and restrictive cardiomyopathy. Now, HOCM, that is hypertrophic obstructive cardiomyopathy. So, all are true regarding hypertrophic obstructive cardiomyopathy except systolic dysfunction. So, what is true? Concentric hypertrophy, diastolic dysfunction, and double apical impulse. All are true about HOCM except that digitalis is useful. What is true? Asymmetrical septal thickness and left ventricular outflow obstruction and double apical impulse. Next, the murmur of hypertrophic obstructive cardiomyopathy is decreased in which of the following? In supine position. A 35-year-old farmer consulted a local medical practitioner for recurrent attacks of chest pain. His elder brother had similar complaints and had died suddenly at the age of 40 years. The farmer was advised to take nitroglycerin sublingually at the time of pain. However, the patient finds that the intensity of pain is increased by nitroglycerin. Most probably, he is suffering from hypertrophic obstructive cardiomyopathy. A 68-year-old man who had a recent syncopal episode is hospitalized with congestive heart failure. His blood pressure is 160 by 80 mm of mercury. His pulse rate is 80 beats per minute, and there is a grade 3 or 4 harsh systolic murmur. An echocardiogram shows a disproportionately thickened ventricular septum and systolic anterior motion of the mitral wall. Which of the following findings would most likely be present in this man? Reduced left ventricular ejection fraction. Aggravation of symptoms of angina in a patient when given nitrate is seen in idiopathic hypertrophic subaortic stenosis. A 16-year-old male is referred by a high school coach for a physical examination before joining the football team. His elder brother had died suddenly during football practice. No autopsy was done. The patient has a loud systolic murmur on chest auscultation. All of the following would be constant with hypertrophic cardiomyopathy except murmur radiating to neck. So, what would be constant with hypertrophic cardiomyopathy? A crescendo decrescendo systolic murmur and brisk carotid upstroke, increase in murmur during Valsalva or standing. Murmur increasing with Valsalva maneuver is HOCM. Murmur increasing with Valsalva maneuver is HOCM. All are true regarding hypertrophic cardiomyopathy except that digitoxin is helpful. So, what is true regarding HOCM? Irregular thickness of septa, dynamic obstruction, and double apical impulse. The 9-month-old child of a diabetic mother presents with tachypnea and hepatomegaly. Echocardiography of the heart showed normal cardiac morphology with asymmetrical septal hypertrophy. Which of the following you will give to treat this child? Propranolol. A young man has history of breathlessness while walking to gym. On examination, he has ejection murmur which increase on Valsalva maneuver. ECG shows left ventricular hypertrophy with deep Q wave in anterior chest leads. He should avoid regular walking in gym, digitalis, sublingual nitroglycerin, and diuretics. All are true about hypertrophic cardiomyopathy except that digoxin is useful. What is true about HOCM? Abdominal pain, jaundice, and bleeding. All are true about HOCM except that beta agonists are useful. So what is true? Asymmetrical hypertrophy of septum, dynamic left ventricular outflow obstruction, and double apical impulse. A 25-year-old basketball player suddenly collapsed while undergoing an athletic event and died, and at autopsy the septum was hypertrophied. The most probable diagnosis is HOCM. 26-year-old man died while playing. His autopsy of the heart revealed myocyte hypertrophy. Diagnosis is HOCM. All are true about hypertrophic obstructive cardiomyopathy except that anterior leaflet movement is delayed. So what is true about HOCM? Asymmetrical septal hypertrophy, systolic ventricular dysfunction is absent, and cardiac output is diminished. All are true about HOCM except beta blockers are not effective. So what is true? Asymmetric hypertrophy of septum, systolic motion of anterior leaflet, and left ventricular outflow obstruction. The systolic ejection murmur in hypertrophic obstructive cardiomyopathy is diminished when a patient lies down. The 9-month-old child of a diabetic mother presents with tachypnea and hepatomegaly. Echocardiography of the heart showed normal cardiac morphology with asymmetric septal hypertrophy. Which of the following you will give to treat this child? Propranolol. All are true about hypertrophic cardiomyopathy except that digoxin is useful. So what is true is abdominal pain, jaundice, and bleeding. Now valvular and congenital heart disease. True regarding mitral valve prolapse syndrome is all except that mostly symptomatic. It is mostly asymptomatic. What is true? More common in female, high incidence of arrhythmia and transient cerebral ischemia can occur. A female patient, Chandni, develops chest pain which is not associated with exercise, and chest auscultation shows multiple non-ejection click. The investigation which is used to diagnose the disease is echocardiography. A young asymptomatic female is observed to have a mid-systolic click on routine examination. Walls are likely to show myxomatous degeneration. All of the following are true for mitral valve prolapse except that majority of the case present with features of mitral regurgitation is wrong. What is true? Transmission may be as an autosomal dominant trait. The valve leaflet characteristically show myxomatous degeneration. The disease is one of the common cardiovascular manifestations of Marfan syndrome. All of the following are true about atrial septal defect except left atrial hypertrophy. So what is true about atrial septal defect? Right atrial hypertrophy, right ventricular hypertrophy, and pulmonary hypertension. A young female presents with a history of dyspnea on exertion. On examination, she has wide fixed split S2 with ejection systolic murmur HWI in left second intercostal space. Her EKG shows left axis deviation. The most probable diagnosis is ostium primum atrial septal defect. True about VSD, ventricular septal defect, is all except that pulmonary oligemia in chest tray. So what is true? Small hole closes spontaneously. Defect is usually in membranous part, and endocarditis is commonest complication. Mitral stenosis is associated with right ventricular hypertrophy. Following is true regarding opening snap. It is a high-pitched diastolic sound. The severity of mitral stenosis is clinically best decided by length of diastolic murmur. Severity of mitral stenosis is assessed by length of murmur. Severity of mitral stenosis is judged by S2-OS gap and prolonged diastolic murmur. The severity of mitral regurgitation is decided by all of the following clinical findings except intensity of systolic murmur across mitral wall. So it is assessed by presence of mid-diastolic murmur across mitral wall, wide split second heart sound, presence of left ventricular S3 gallop. Severity of mitral regurgitation is associated with atrial fibrillation and LV S3 left ventricular S3. A 59-year-old man with severe myxomatous mitral regurgitation is asymptomatic with a left ventricular ejection fraction of 45% and an end systolic diameter index of 2.9 cm per meter square. The most appropriate treatment is mitral valve repair or replacement. All of the following murmurs may be heard in patients with aortic regurgitation except pansystolic murmur. So, which murmurs can be heard in patient with aortic regurgitation? High-pitched decrescendo diastolic murmur, soft low-pitched mid-diastolic rumbling murmur, mid-systolic ejection flow murmur. Next is aortic regurgitation does not occur in acute myocardial infarction. It can occur in Marfan syndrome, rheumatic heart disease, or infective endocarditis. Acute aortic regurgitation is seen in all of the following except acute myocardial infarction. It can be seen in Marfan syndrome, bacterial endocarditis, and ankylosing spondylitis. A 35-year-old athlete has height 184 cm, arm span 194 cm, pulse rate 64 per minute, BP 148 by 64 mm of mercury. Chest auscultation reveals long diastolic murmur over right second intercostal space on routine examination. The probable diagnosis is aortic regurgitation. A young basketball player with height 188 cm and arm span 197 cm has a diastolic murmur test heard in second right intercostal space. Likely cause of murmur is aortic regurgitation. Wide pulse pressure is seen in aortic regurgitation, patent ductus arteriosus, and mitral regurgitation. A 63-year-old man presents with a triad of angina, syncope, and congestive heart failure. Which of the following valvular heart lesion can be suspected? Aortic stenosis. Angina pectoris and syncope are most likely to be associated with aortic stenosis. In severe aortic stenosis, true finding is ST segment deviation in ECG. Which of the following physical sign is seen in a patient with severe aortic stenosis? Delayed peak of systolic murmur. A 50-year-old man with aortic stenosis is doing exercise for 11 minutes according to Bruce protocol. Exercise stopped due to fatigue. Regional pressure gradient is 60 mm of mercury between the two sides of the aortic wall. What is the best management? Observation. All of the following are true regarding tetralogy of Fallot except that predominant left to right shunt is wrong. What is true? Ejection systolic murmur in second intercostal space, single second heart sound, and normal jugular venous pressure. Essential criteria for tetralogy of Fallot include all except valvular stenosis. So it includes infundibular stenosis, overriding of aorta, and right ventricular hypertrophy. Fallot tetralogy manifestation is VSD. Blalock tossing shunt is between pulmonary artery and subclavian artery. Peripheral pulmonic stenosis is associated with Williams syndrome and rubella. The most common causes of tricuspid regurgitation is secondary to dilatation of right ventricle. All can cause recurrent pulmonary infection except tetralogy of Fallot. So recurrent pulmonary infection is not caused by tetralogy of Fallot. It can be caused by ventricular septal defect, recurrent left ventricular failure, and ASD. Pressure difference of 5 mm mercury between the two upper limbs occur in which congenital heart disease? Supravalvular aortic stenosis. All of the following findings would be accepted in a person with coarctation of the aorta except inability to augment cardiac output with exercise. So what is the finding which can be seen in coarctation of aorta? A systolic murmur across the anterior chest and back and a high-pitched diastolic murmur along the left sternal border. A higher blood pressure in the right arm than in the left arm. Persistent hypertension despite complete surgical repair. Next is a 27-year-old man is noted to have blood pressure of 170 by 100 mm of mercury. He has a prominent aortic ejection click and murmur heard over the ribs on the both side anteriorly and over the back posteriorly. In addition, the pulses in the lower extremities are feeble, and he complains of mild claudication with exertion. The most likely diagnosis is coarctation of the aorta. A patient presents with a headache, intermittent claudication, and dizziness. Which of the following may be the underlying cause? Coarctation of aorta. A 41-year-old girl, uh, a 4.5-year-old girl always had to wear warm socks even in summer season. On physical examination, it was noticed that she had high blood pressure and her femoral pulse was weak as compared to radial and carotid pulse. A chest radiograph showed remarkable notching of rib along with their lower border. This was due to coarctation of aorta. All of the following causes death in coarctation of aorta except anterior myocardial infarction. So, what are the causes of death in coarctation of aorta? Infective endocarditis, CCF, that is congestive cardiac failure, and intracranial hemorrhage. A patient complains of intermittent claudication, dizziness, and headache. Likely cardiac lesion is coarctation of aorta. Coarctation of aorta is associated with all except pulmonary stenosis. It can be associated with Turner syndrome, bicuspid aortic valve, or atresia of aortic arch. Coarctation of aorta is most commonly associated with bicuspid aortic valve. Coarctation of aorta is most commonly associated with bicuspid aortic valve. Coarctation of aorta may be associated with all of the following except renal artery stenosis. It can be associated with bicuspid aortic valve, Turner syndrome, or patent ductus arteriosus. All are associated with coarctation of aorta except renal artery stenosis. It can be associated with PDA, bicuspid aortic valve, or Turner syndrome. Rib notching is seen in all except IVC obstruction. So it can be seen in coarctation of aorta and classical Blalock tossing operation and neurofibromatosis. A 2-year young man presents with exertional dyspnea, headache, and giddiness. 22-year young man. On examination, there is hypertension and left ventricular hypertrophy. X-ray picture shows notching of the anterior end of the rib. The most likely diagnosis is coarctation of the aorta. Most common cause of death in adult with patent ductus arteriosus is congestive cardiac failure. Causes of cyanosis is tetralogy of Fallot, tricuspid atresia, Eisenmenger complex, TGA. Patent ductus arteriosus is not a cause of cyanosis. Pulmonary flow is decreased in Fallot's tetralogy and Epstein's anomaly. Congenital heart disease associated with decreased pulmonary blood flow, Epstein's anomaly, and single ventricle with pulmonary stenosis. LVH, left ventricular hypertrophy, is commonly seen with aortic incompetence. Right axis deviation is seen in all except tricuspid atresia. So, right axis deviation is seen in ventricular septal defect, pulmonary atresia, and atrial septal defect.